Okay, so we're going to be studying skin infection, and in skin infections, we are looking at bacterial skin infections. We are going to also be looking at bacterial. We're going to look at mycobacterium related skin lesions and also some viral skin lesions. Uh, so first of all, we're going to begin with bacterial and skin lesions. All right. So bacterial skin lesion. First bacterial skin lesion that I want to talk about is pyoderma. Pyoderma is nothing but pyo means pus and derma means dust. Derma means involvement of the skin. Pyoderma can be of two types. One is the follicular type, one is the non-follicular type. The follicular pyoderma and the non-follicular pyoderma are seen. Now the follicular pyoderma is obviously of three types. One is folliculitis, the other is a boil or a furuncle. Folliculitis. One is a boil or a furuncle, and the other is going to be a carbuncle. All right. So folliculitis, follicular pyoderma is the most common cause is going to be Staph aureus, and the disease is going to be folliculitis. Folliculitis is when it is around the hair follicle, let's say if this is the hair follicle, this is folliculitis. It's oriented around the hair follicle, or it's just simply the infection of the hair follicle. Pustule is around the hair follicle, so obviously when you look at the disorder, there is, if this is the hair follicle, you're going to have a little bit of a pustule around. One is folliculitis, the other is going to be obviously your furuncle or the boil. So let me write furuncle, let's not write boil because that's too rudimentary. So infection of the hair follicle, let's say if this is the hair follicle, there's going to be infection of the hair follicle. Let me make it red. There's going to be infection of the hair follicle and also about the area around the hair follicle. So this is something called as a boil, and obviously you've seen what a boil looks like, obviously. And third is going to be your carbuncle. Carbuncle is infection of multiple hair follicles. Out here there's only one hair follicle. Let's say if there are 2, 3, 4, and this is your skin, and you're going to have infection of multiple hair follicles. So obviously there's going to be infection of multiple hair follicles, and also there's going to be a lot of infection that is spread around the contiguous area or the adjacent area. And because of this is what a carbuncle looks like. And carbuncle is usually on the neck, it's on the trunk, the upper back. And what does it appear at? It appears as a red, that is erythematous, discharging lesion. So there is going to be lesions that is discharged because it's a pus, that could have pus. How do you want to treat it? You want to treat it by using systemic antibiotics and antibacterials. Also, what you want to do is you want to do a surgical debridement. So you want to do a surgical process called a surgical debridement, or you want to and followed by incision and drainage, right? And drainage. So that is about the follicular pyoderma. Coming to the non-follicular, sorry for the change in font. Non-follicular, that means that's just not classified or oriented to hair follicles. So we have two types in non-follicular. Let me change the color. We've got two types in non-follicular. One we've got is localized, and we've got spreading or generalized, if you want to use it. In localized, you've got impetigo and you've got ecthyma. And in spreading or generalized, what you've got erysipelas, and you've got cellulitis. So what is impetigo? Impetigo can be of two types. Impetigo is of two types. One is the bullous impetigo, and the other is the non-bullous impetigo. Now the bullous and non-bullous. So which one is seen? This is by strep, staph also, by strep also, strep pyogenes. It gives a honey crust appearance. And where is it seen? It's perioral, perinasal, in children. All right. But what about a bullous impetigo? Bullous impetigo is by Staph aureus, by its toxin-mediated epidermal exfoliating toxin or epidermolytic toxin. There is a hypopion sign. And the crust is a varnish crust. What do you mean by that? Well, actually, when it ruptures, let's say one of these bullays, because it's bullays, obviously there are going to be bullays, so these bullays are going to have pus settling down, and when this pus ruptures, it causes a varnish crust. Where are the sites? Obviously, it's going to be the bulbous one is on the trunk. How do you want to manage? You want to use treatment. You want to use a treatment procedure as fusidic acid, mupirocin, ozenoxacin, ozenoxacin. This is a fluoroquinolone. Remember that. So you want to use a fusidic acid, mupirocin, and ozenoxacin. Coming to the next one. We saw about impetigo. What is the other one? The other one is ecthyma. 1, 2, 3, 4. First is done. Second, ecthyma. Let's go at ecthyma. Directly, let's take shots at ecthyma. What is ecthyma? Ecthyma is ulcerative. So let's say if there's impetigo, impetigo shows deep involvement or deeper involvement. If it's deep or it's ulcerative. Deep/ulcerative. Straight up. You're done. It's ecthyma. Obviously, what's going to be a strep? What's going to be etiology? It's going to be a strep. Again, a strep, a group A streptococcus, that's going to be mostly a pyogenes. What's going to be, lesion is going to be a hard crust. And on removal, it's going to show a purulent ulcer. So these crusts are going to be over the ulcers. So if this is your ulcer, there's going to be a hard crust over it. So when you remove it, obviously you can see a purulent ulcer. Coming to next, the systemic or the generalized non-follicular pyoderma. First, we've got erysipelas. What are erysipelas? Erysipelas again caused by what? Streptococcus. Pyogenes A. So I'm gonna write strep A. What is it? What is it gonna? Where's the pathology? The pathology is actually associated in upper dermis. Upper dermis plus lymphatics. All right, and how's the lesion? The lesion is a well-defined lesion. It's got raised margins. All right, it's a well-defined lesion. It's got a well-defined lesion. It's well demarcated from the normal skin, and it is erythematous. Obviously, it's erythematous. It's indurated as in hardened. It's hardened. And it's a plaque. It's a tender plaque. That means on application of pressure, obviously, it's going to be painful tender. Where is it actually located? It's located on the lower extremities. It's located on the face. It's located on the lower extremities. And also, it can go and involve the pinna. So it's just red erythematous plaque. Coming to the next one, that is going to be your cellulitis. Here, it's going to be strep and staph plus staph. This lesion is not going to be well demarcated, so I cannot draw this. What I should draw is definitely, this is your lesion, and it's not well demarcated, and the margins are also not well demarcated. The margins are ill demarcated. They are diffuse, correct? And what area does it involve? The patho, if I have to talk about the patho, it involves the lower dermis. But the erysipelas involve the upper dermis. Lower dermis, and what else? It involves also the subcutaneous fat. The subcutaneous fat. Alright, so which parts is it involving? It's involving the lower extremities. And the pinna is spared. Pinna not involved. Alright, so that's cellulitis. We've seen the pyoderma conditions. Now let's look at Staphylococcus caldensins syndrome. SSSS. The 4S. What is it caused by? It's caused by staph. Man, the name gives it all. Why? Because of the epidermolytic toxin or the exfoliative toxin. Correct? Epidermolytic toxin. So let's say if this is your person. He has a lesion here, or let's say he has a lesion in his eyes, a staph conjunctivitis, and he is having a lot of epidermolytic scalded skin syndrome. Why? Because what happens is that the toxin that's present, it goes into the bloodstream, and it reaches all different parts of the body, and what it causes is that it attacks the DSG1, desmoglein protein 1, and desmoglein protein 1 causes splitting of the skin in the upper epidermis, that is around the stratum corneum, and it causes acantholysis. It causes acantholysis, and because it causes acantholysis, it also shows positive Nikolsky or true Nikolsky sign. What that basically means is that when we take a glass slide, let's say this is the glass slide and this is your lesion, and when you apply pressure, obviously the lesion is going to separate because of acantholysis. So this is what we called as Nikolsky. I've spoken about this also, Nikolsky sign, correct? Mucosa is usually normal. The mucosa is normal because DSG is not present in DSG1 is not present in the mucosa, rather DSG3 is present, and that is what we see in pemphigus. Correct? Pemphigus vulgaris shows DSG3 involvement, and obviously sheet-like epidermal peeling is seen. Sheet-like epidermal peeling. So this is the epidermis. The epidermis is going to come out. What next? What next are we looking at? Next, something that we are looking at very interesting is going to be acute paronychia. What is paronychia? Paronychia. Again, this is a bacterial condition. Paronychia. It could be it's infection of the nail fold. So the nail fold shows infection, and obviously it starts first with it just starts with erythema. First there is erythema, there is redness, and then there is a pus, and then the pus becomes an abscess, and when it becomes an abscess, it needs drainage. What is the cause of it? Obviously it's Staphylococcus aureus. Botuliomycosis, nothing to do with fungus, Botuliomycosis, nothing to do with fungus, but B is bacteria. What bacteria is it going to cause? It's going to be caused by Staphylococcus aureus. Again, most common is Staphylococcus aureus, but also E. coli, Klebsiella, and the Proteus. All the Enterobacters can also cause it. But obviously, what is it? What is the lesion? The lesion is just simple. It's a chronic suppurative granulomatous response. So what is going to be? There's going to be a nodule plus granulations, a granulomatous lesion. Because it's a chronic granulomatous suppurative response, granulomatous lesion. Correct, that about being it. Now next we have is erysipeloid. What is erysipeloid? There's nothing to do with erysipelas. Erysipeloid is again red. Alright, it's an erythema, because erythema, erysipeloid, erythema, painful plus painful. What is it? It's a painful plus there's also edema. Also very similar to erysipelas, obviously very similar to erysipelas. But what is the cause? The cause is going to be something that is coming from the name directly. Erysipelotrix. Let me write it properly again. Erysipelotrix Rhusiopathy. Basically, it's a bacteria that is from meat or from fish. So it's seen in meat and fish handlers. Obviously, next we are looking at is Corynebacterium infections. Not diphtheria. Usually, diphtheria is not very commonly seen. So first let's talk about, so we spoke about erysipeloids, we spoke about botuliomycosis, we spoke about acute paronychia. All right, we spoke about all of these. Now paronychia, we've also spoken about the very famous SSS, we've spoken about the cellulitis, erysipelas, all of these should be remembered. Now coming to Corynebacterium diphtheria infection, we have something called as an erythrasma. What do we have? We have something called as erythrasma. Erythrasma is by Corynebacterium minutissimum. Alright, what is going to be the lesion like? It's going to be hyperpigmented macules. It's going to be hyperpigmentation. Macules, not bad. Why does it occur? It shows fluorescence on wood lamp positive. Due to coproporphyrinogen 3. Alright, you know what a coproporphyrinogen is, right? It's the pigment. And treatment you want to use, again, you want to go for erythromycin, which is a macrolide, or you want to go for a fusidic acid that we also use in... Where did we use a fusidic acid, mate? We use fusidic acid also in impetigo. Alright, come next. We have something called as a trichomycosis axillaris. Not very important, but yet T. Talk about T. Corynebacterium tetani. Alright. What is it? the complaint is going to be yellow hair. Yellow hair, why? Because of the deposit over the hair shaft. Obviously, again, the sites is going to be the axillary region, sorry, just like your erythrasma, which is caused by Corynebacterium minutissimum, and axillary part. And the treatment is going to be clindamycin, or you just can shave off your hair, which is the better one actually. Then we have something called as a pitted keratolysis. Pitted keratolysis. Why is it? What does it cause? Pitted keratolysis. The cause is also something called as Chytococcus dentarius. A messed up name, not very important. Pits and craters are seen. Pits/craters in stratum corneum. Obviously on the palms and soles. It's seen in farmers actually. So obviously when you're looking at the Corynebacterium infection, if they ask you which of the following is not a Corynebacterium infection, obviously first you want to keep in mind is that you could have pitted keratopathy or keratolysis. You could also have this very particular condition called as trichomycosis axillaris. If just in case my handwriting is too bad, trichomycosis and axillaris. Nothing too great. And obviously I told you T, so Corynebacterium tetani. And the last one is going to be erythrasma. Erythrasma is by Corynebacterium minutissimum. All right. And pitted keratopathy, it's by a micrococcus. Rather than writing this entire messed up name, let me just tell you that it's by micrococcus. In case an MCQ comes, you have to keep in mind that K for keratopathy, K for something called as a Chytococcus dentarius. Chytococcus dentarius. That being about it. Now about the Pseudomonas infections. Now we've spoken about the Corynebacterium infection. So let's talk about the Pseudomonas infection. Pseudomonas. So obviously you have something called as an ecdyma. What do you have? Ecdyma. Gangrionosum. Or gangreosum. What is it? It's just an hemorrhagic necrosis of skin, and it is actually as seen as Pseudomonas septicemia. So this is a very important erythema gangrionosum of the skin. And then we have something called as a hot tub folliculitis. Also we have something called as a green nail syndrome. Hot tub. On the trunk you see certain lesions, all right, because of folliculitis, just simple folliculitis. And green nail, you have it because of the pyocyanin that's present in the Pseudomonas. That's just some important MCQs that could probably come. Obviously next is you have very important this bacteria as anthrax, so it can cause cutaneous anthrax. Anthrax is usually painless. Then it starts as a planus papule. It becomes an eschar. It becomes a black eschar with an necrosis in the center, and then it becomes a malignant pustule. Because there's nothing malignant about it in its sense, but just that this is supposing your eschar, and there's going to be a rim of vesicles that are around the eschar. A very other important and very classic, this is a good question that can come up, is meningococcemia. What does it lead to? It leads to petechial rash that is seen on the limbs, and obviously you're going to see fever plus sign of meningitis. So it just can come as a clinico-pathological question as a patient comes or a young dorm student comes. They can add another very important syndromes that could be associated with this particular disorder. And a very another important mycobacterial disorders, scrub typhi caused by Orientia susugami or Susugamushi. Susugami is fine. It's transmitted by a mite. It's obviously bite by mite. It is the larval form is infected, and obviously you're gonna have fever. You're gonna have CNS. You're gonna have symptoms of meningitis probably. But what is the lesion is that it's an eschar. And how you want to treat is that you want to use a doxycycline. Whereas when it comes to meningococcemia, depending upon what stage it is, you could go for ceftriaxone or you could go for a rifampicin. All right. So what was important or what was new actually, apart from normal basic microbiology, uh, was the corynebacterium path, where we saw certain new corynebacteriums, atypical, that were not usually focused upon, because we always check the diphtheria. So we saw erythrasma, we saw the uh, axillaris, trichomucosis axillaris, again by tetany, yellow hair. That's being about it. And you also saw pitted keratopathy, where just pits are seen. And I think which are seen on the palms and the soles. Apart from that, I do not really think there was something that was very new. Erythrasma. I just name a few disorders before we leave. Skin infection. When it comes to bacterial, obviously you want to keep in mind pyoderma. Pyoderma. Let's have a recap. Pyoderma. You could have a folliculitis. If it is follicular pyoderma, you could have a folliculitis. You could have a furuncle. You could have a carbuncle. All right. Then you go in and that is pyoderma. Then you could have an SSS. All right. Then you could have, what else could you have? You could also have uh, paronychia. You could have botryomycosis, again by botryomycosis, again something by Staphylococcus aureus, most commonly a chronic granulomatous inflammation. Or you could have a erysipeloid. Erysipeloid is something that is seen by a bacteria that is named after the very disorder itself, Erysipelotrix rosipathy. Then you could have a disorder that is associated with Corynebacterium diphtheria. Corynebacterium species, not diphtheria. Minimatism, if it is involved with, so then it's going to be a very important disorder called as erythrasma, which is erythrasma. Again, similar to not similar exactly, it's going to be a hyperpigmented macule because of the uroporphyrin. Also, you could have is trichomycosis axillaris, where you could have yellow hair. Okay, that's something that's done. Erythrasma, yellow hair. Erysipeloid is done. All right, we're talking about pitted keratosis. Pitted keratosis is again a very important disorder, where again the disorder lies in the stratum corneum. Again, it's seen in a micrococcus of corynebacterium. And then we have to talk about Pseudomonas species. We see erythema gangliosum, we see a hot top folliculitis, and we see green nail syndrome, all of which we have seen. Then we have anthrax. Anthrax is a black eschar which follicles surrounded with, that we have seen. And then we have also seen of Neisseria gonococcus, that could lead to petechia. And then obviously we have scrub typhi. That could again lead to an eschar and fever and CNS signs. And another one was Neisseria meningococci or meningococcemia. That being about it, we have done with the bacterial skin infections. Thank you.